To be here today. My name's Kelly Egan. Again, she, her pronouns. I have no disclosures to report. And today I'd like to go through these 4 learning objectives. Essentially, first to talk about why language matters. And perhaps this is, in my opinion, one of the most important things. The stigma associated with people who use drugs, as well as people with HIV and AIDS, is real, and so language matters. To explain some of the current epidemiology of HIV and substance use, with a focus on rural populations, which is part of the reason most of you came to this talk, I expect. And then to outline the bidirectional interaction between HIV and substance use disorders. And then lastly, to talk about some common screening tools that one might use in their practice, to identify patients who are at risk for substance use disorders. There is a second talk a few weeks from now on September 28th, and I'll at the end sort of share some of the objectives of that talk. So if this seems sort of like got you halfway there, then come to the second half and you can get the rest of the way there maybe. So this is a picture of the clinic that I worked at immediately after I finished residency. So as Susan said, I completed my family medicine residency at UCSF, which is University of California, San Francisco, and stayed in San Francisco and got a job working for the Department of Public Health. San Francisco DPH has a network of primary care clinics. And this was the most heartfelt place I've ever worked, and really where I found my place in medicine. It was a hole in the wall in the Tenderloin neighborhood of San Francisco, if you've been there and are familiar with it. It was a clinic established with the goal of taking care of people who were experiencing or formerly homeless, also with a focus on transitioning people into permanent supportive housing. And in working, it was a clinic for adults, and in working with this clinic and the work I did for 9 years for the Department of Public Health, I encountered quite a lot of substance use, mental health disorders, as well as all the other chronic conditions that come along with living in this country, and especially living in situations of poverty, which was prevalent across all my patients. So I did this needs assessment related to accessing hepatitis C treatment, and it involved interviewing a number of patients. And one of the patients said this quote, which is heartbreaking and extraordinarily telling, and I think relevant, despite the fact that this isn't about hepatitis C, to this work. And I actually don't even know if it was a he or a she, but they said they don't treat people like me. And that was the reason why they said they hadn't been able to get hepatitis C treatment. And I don't know what like me meant. I don't remember the specifics of who this was, but like me can mean somebody like me who doesn't have a roof over my head, or somebody like me who uses drugs, or somebody like me who suffers from depression, or somebody like me who has sex with men or not with men. And, there's so many like me's that our patients identify with. But the take home was that they don't treat people like me because there's stigma and there's shame, and those are conditions associated with people like me. And I think that they don't treat people like me, or perhaps they don't treat people like me well or compassionately, really is true in the world of addiction medicine, which is my specialty. And also is relevant to people with HIV and AIDS who have faced discrimination and stigma. And so while heartbreaking, I think that this is really important to remember that this is the experience of our patients, that they feel ostracized and outside of our medical establishment. And so remembering to bring compassion and fairness and equity to care is important. So the basics, what is addiction? In its most formal definition by the American Society of Addiction Medicine, addiction is a treatable, and that's really important, chronic medical disease that's complex. It involves brain circuits, genetics, environment, and one's life experiences. People with addiction use substances or have behaviors related to their substance use that become compulsive and continue despite harmful consequences, and that compulsivity and the use despite harm are really hallmarks of addiction. But also importantly, prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases. So sometimes people say to me, like, they kind of ask what I do, and I talk about the fact that I work in the world of addiction medicine, and they sort of just feel this futility. And I don't feel that way at all. I see tremendous improvement in health and behavior changes and redevelopment of relationships and sense of purpose in my patients, and I really find it satisfying. So what is substance use? This is a big umbrella, sort of umbrella term, but generally, and it's always kind of changing, but the preferred terminology is first we talk about low risk use. So that might be no use at all, or that could be use that falls below what is generally thought to be physically or psychosocially hazardous. And then there's the other big overarching umbrella, which is unhealthy use. So that's use that's hazardous, harmful, so either has the risk for negative consequences or has caused negative consequences to one's health. And then there's dependence, meaning that the body is used to getting a certain substance on a daily basis, and by stopping using or not having access to that substance, one would go through a withdrawal syndrome. That would be like a clinical presentation of symptoms that indicates their body is in withdrawal from a substance. Substance use disorder, I'll talk about more, but is the clinical diagnosis that we use. And then addiction is sort of more the overarching term. Terms we don't use anymore is problem use. The word problem in and of itself implies sort of a negative or negativity, and it associates more judgment and stigma. Misuse and abuse are vague and are no longer the currently preferred terminology. So I mentioned on the last slide, substance use disorder. So substance use disorder is a clinical diagnosis defined by the DSM-V, which is the Diagnostic and Statistic Manual of Mental Disorders. But it is there are 11 criteria, and I don't need to read through them all, they're here, but this is what a clinician will use to determine if somebody meets the criteria for a substance use disorder. And in some ways, it's sort of splitting here, because substance use cannot meet the criteria for a substance use disorder and still have tremendous negative consequences on one's life. So an example might be using a pill or something bought off the street and having an overdose. And that is a very significant negative health consequence, life consequence. But if it doesn't sort of meet these criteria to define a substance use disorder, it doesn't meet that criteria. But again, it's really important to be specific in how we make our diagnoses. But substance use can be harmful even if it doesn't meet this sort of more formal definition. So I think it's important to recognize both. But the categories fall into impaired control that results from substance use, social impairments, especially in important roles in one's life, family relationships, risky use, and then pharmacologic. So this means that somebody develops a tolerance, meaning they require more substance over time or a higher quantity to achieve the same effects. And withdrawal, which is when they stop using, their body goes into a withdrawal syndrome that demonstrates that they have dependence. And then this diagnosis can be graded as mild, moderate, or severe. So it's a term you'll hear me use a lot, SUD, substance use disorder. And this is what it is. And it really just sort of marks or grades the severity of one's problems with substance. So does language matter? This is, people have attempted to study this in a more rigorous way. And in 2010, a study was published in the International Journal of Drug Policy, looking at a controlled, randomized controlled trial between, it was held with mental health professionals. And they talked about a clinical scenario using, in one group, the term substance abuser, and in the other group, person with a substance use disorder. And those who heard about the person referred to as a substance abuser were generally found the person to be more personally culpable and thought punitive measures should be administered or taken. And this speaks to the fact that the words we use matter a lot in life, but specifically in addiction medicine. There's a lot of language that is commonplace, and maybe if you don't even think about it, you don't realize sort of the implications it has. When talking about urine toxicology screening, patients themselves will say clean and dirty, but really that has a very judgmental effect. And so we prefer things like expected urine results or unexpected urine results. And then there were, people might say, but I've heard the word abuse forever. Well, yes, you did. It actually used to live in the DSM that I mentioned previously. But in the 4th to 5th edition, the language shifted from dependence and abuse to substance use disorders. I'm not going to read through all of these, but these are some terms that welcome you to come back to this slide and look through in a little bit more detail. But, words that I would recommend not using to talk about people, to not talk directly to clients. Sometimes people will say, well, my clients say these things themselves. And sometimes they do, but that's sort of learned. They've learned that that's how people see them in our world, and people are judging them and seeing them as, with the stigma that comes with this field. And so I try to use more objective and less judgmental language, and talk to patients about why I'm doing that, to empower them to have pride in themselves. Just some abbreviations that you'll see throughout the presentation. People who use drugs, people who inject drugs, they're different things because not all drugs are injected, but so that's a subtle difference. And then injection drug use is IDU. Previously, many people just use IVDU, like intravenous, but a lot of drugs that are injected into the body don't go into veins, and intravenous implies veins. So drugs can be injected into muscles or subcutaneous tissues, and they're just injection drug use. And then the substance use disorder, SUD, can be sort of specified as an opioid use disorder, an alcohol use disorder, and then PWHA is people with HIV or AIDS. So I don't need to probably tell anybody, unfortunately, people know that we are in crisis in our country when it comes to substance use. And in the last year, we surpassed over 100,000 deaths. The United States surpassed 100,000 deaths in a 12-month period. To compare, looking at the number of HIV deaths in a 12-month period, there was only almost 16,000. That's not an only, but almost 16,000. But a fraction of the number of deaths attributed to overdose. And why is this number rising and continuing to rise? And the reality is that this is being driven by synthetic opioids that are flooding our drug supply. So specifically fentanyl and other synthetic analogs of fentanyl. And it used to be that fentanyl or opioids were found, or mostly opioids were found in opioids. And so people seeking out opioids were at greater risk from an opioid overdose. Now we know that many of the stimulants, so cocaine and methamphetamines, are contaminated with these synthetic opioids. So people who don't even seek out opioids are unexpectedly encountering opioids and having opioid overdose deaths. And then, other drugs alone, or polysubstance use, where there's multiple drugs in the system, comes with an increased rate of death as well. So we're just seeing a tremendous rise, and it's a reason to have more attention and to take more action. So what do we know about substance use in our country? This is general. It's not specific to rural populations or people with HIV or AIDS initially, but there is a large survey that's completed every year. And this data comes from the 2020 report. But it surveys adults, actually people 12 and up, over 50 states. Notably does not include institutionalized people. So people who are in the prison or jail system are excluded, and that's notable because we see a high prevalence of substance use in those populations. So it's not without its limitations, but it still gives us a good picture. So in the last year, 138.5 million people use alcohol to some level. That's 64% of this population. 44% classify as binge use. Binge use is kind of using a lot in a small period of time that rapidly raises your blood alcohol level to the level of legal intoxication, like 0.08. And then they sort of further break down into heavy alcohol use, but that is somewhat similar, just a slightly subtle definition difference. But that's a lot of people in our country, and I think most people recognize that alcohol use is normalized in our culture, and is often not seen as harmful, but can have really serious consequences. Tobacco use in the last year is 57 million, or 21%. And then illicit drug use. So this is lumping all substances that are illegal together, and that comes to 59 million. And the most common is marijuana, which, as I reviewed the slides yesterday, I recognized, wow, that's complicated because marijuana is now legal in certain states, but for the purpose of this survey, it's considered illegal. So it gets a little convoluted, perhaps. But then thinking about opioid use, 9.5 million people reported any opioid use in the last year. Um, and it's a relatively small percentage of our entire population, though 3.4% of our entire US population is still a lot of people. Of these, the majority reported actually unprescribed pain relievers, and I don't quite know what that means, or I'll mention in a second the problems there. And then nearing 1 million report heroin use. And if you look at this graphic at the bottom, it kind of breaks down by substances. So I didn't list out in the bullets, but you can see where things like cocaine and stimulants and methamphetamines fall, kind of in the middle of the pack. Also not spelled out in all the numbers, but when they say tranquilizer or sedative misuse, that's the category of benzodiazepines, which is like an thought to be by some people an anti-anxiety medication, but is really a very dangerous substance because one can develop both dependence to it that can be life-threatening if they withdraw from it, and it also is very dangerous when combined with alcohol and opioids because it greatly increases the risk for overdose. So I said this unprescribed pain relievers is like kind of nebulous and scary to me. And the reality is I say, what's in those pills? And I bring this up because the reality is that my patients talk to me all the time about the fact that they like buy oxys on the street or they buy whatever they think a Xanax bar, whatever they call it, or they say it is. And we don't know what the heck that is. We know it's dangerous is what we know, but when people are reporting buying things on the street, they are not getting pharmaceutical grade drugs. They are getting substances that come from labs or other sources. There are these things called pressed pills, and they almost always are containing fentanyl these days. So again, really raises the risk for overdose and death. This is a lot of details in one slide, but just kind of the past couple slides, we're talking about use, like use of alcohol, use of tobacco, but not meeting the criteria for a substance use disorder. And those things can be really different. A lot of us use a substance, but don't use it to the degree where we would have a use disorder. So this is trying to estimate better at who actually gets to that clinical diagnosis of a use disorder. And bottom line, it is still a lot of people. 40.3 million people have a substance use disorder in our country. And you see the green overlap in the middle is those are people who have both alcohol use disorder and some injection drug use disorder, which could be opioids, could be stimulants, but a lot of polysubstance use is happening. So then pivoting to HIV. So what do we know about HIV? Well, we have an estimated 1.2 million total infections with still about 13% unaware of status. There's about almost 37,000 new diagnoses in 2019. About 2/3 among gay and bisexual men, about a quarter almost among heterosexuals, and then 7% among people who report injecting drugs as their risk factor for HIV. Oopsies, I went the wrong direction. Interestingly and good that the HIV diagnoses are relatively stable among people who inject drugs. So injecting drugs is a significant risk factor for HIV acquisition, but the rates of people getting diagnosed with new HIV infections has been relatively stable. But there have been studies to show that among people who inject drugs, they have relatively low rates of HIV testing, despite the fact that that is a big risk factor for acquiring HIV. So only 50% of people who inject drugs have had an HIV test in the last year, and arguably that should be much higher. So there may be more people among the population of people who inject drugs that are living with undiagnosed HIV and therefore transmitting or at risk for transmitting. And then I'll talk more about, there's not just, people like to spell out injection drug use as a risk factor for HIV, but a lot of other substance use can increase the risk for HIV infection as well. And I'll talk more about that. It's necessary to highlight that, unfortunately, people of color continue to be disproportionately affected by HIV. Black and African Americans and Hispanic Latino populations made up the majority of new diagnoses in 2019. And kind of interestingly, rates of substance use, substance use affects people of all walks of life, though often the outcomes can be different, related to access to treatment and stigma and many other factors. So despite relatively similar rates of substance use among races and ethnicities, we know that African Americans are more likely to be arrested related to their substance use, and minority populations face far more barriers to accessing treatment. And then we think about, let's put the rural overlay on all of this. And it's kind of, I guess the best way to talk about it that came to mind for me at least was to talk about Scott County, Indiana, and what happened in this county in 2014 and 2015. Scott County is a small rural community in southern Indiana where tragically in 2014 to 15, there were 215 new infections among a population of only 24,000. And risk factors that made it the perfect storm for this outbreak included rising rates of injection drug use, specifically opioids, very limited medical services in a rural community, specifically including really minimal access to HIV testing, and then for people who are infected in the beginning, no access to treatment located within that county. There were no substance use treatment programs, so people who perhaps had substance use and even wanted treatment couldn't access it readily. And there were no harm reduction or safer injection services available. And then significant stigma associated both with HIV and with substance use. So thinking about rural areas and substance use, there are some specific factors more unique to rural areas. Overall, there can be lower educational achievement, so perhaps less health literacy and lower literacy about risks for HIV or treatment options for HIV or substance use, higher rates of people living in poverty, limited access to medical care, especially substance use, mental health, and HIV, geographic barriers. I will admit, like I lived in San Francisco for 13 years, and almost everybody I took care of could walk to my clinic. And then I moved to Wisconsin, where I see people who are getting like airlifted in from northern Wisconsin. And I'm then faced with putting together a treatment plan for them to return to their rural county in northern Wisconsin. And it's been a steep learning curve and really important for me to understand how different care can look and how many barriers people can encounter that makes the reality of putting together a comprehensive plan really difficult. People, then sometimes it can be easier to get street opioids or to like self-medicate with whatever one is able to get from friends, family, purchased on the street, than it can be to actually go see a doctor in these communities because of healthcare provider shortages and things like that. There's isolation, stigma, and as I said before, limited harm reduction services. And then chronic pain is, I think also notable. We know that studies have shown higher rates of chronic pain in rural versus urban populations, and then lower access to non-pharmacologic treatments, be that yoga, meditation, acupuncture, cognitive behavioral therapy. And more recently, a study actually showed, and this keeps being highlighted, the pendulum has sort of swung from people treating pain with opioids to now people being much more cautious and conservative about the use of prescribing opioids. And so, many of you may have heard that over the last 5 years or so, many physicians and other prescribers have become more judicious, so to speak, about their prescribing, but this has resulted in people previously prescribed opioids, perhaps with no problems whatsoever, being discontinued or having their dose reduced, and that can come with some really significant consequences. And so at least one study has shown increased overdose deaths and suicides after prescription opioids were discontinued. So Scott County had this set up for the perfect storm. Rising rates of injection drug use, really limited medical access, limited treatments for people with substance use disorder, no harm reduction services, and there was this rapid uptick in new HIV infections. And the response was really, really slow and has been criticized as too slow. But what changed things? Initially, there was an executive order from the governor to allow syringe exchange. So that was the setup of a program where people could come in to get clean syringes, as well as all the other equipment that people use when using drugs, because we know that the virus can be transmitted not only on syringes, but in the other sort of accessories that people use. There was then there was also increased, sort of a one-stop shop was created to have a place where people could get referrals to substance use treatment, to have harm reduction programming, to do HIV testing, and importantly, to enroll people in Medicaid or insurance so that they could then access care. Because if one can't afford it, they probably aren't going to be able to access the medical treatment that they need if they either want an HIV test or find out that they have HIV and need treatment. And then also really important, there was a big push, and this was very grassroots, to educate the community and to talk about to have an anti-stigma campaign to try to make it more acceptable to talk about substance use and HIV and recognize that this was a failure of our system, not a failure of individuals. So thankfully, those responses curbed this outbreak, and no longer were rapid, high numbers of people being infected with HIV. But the CDC then did an analysis looking at our whole country to try to identify vulnerable counties. And so the counties in pink were identified as counties that are at risk for outbreaks of HIV or hepatitis C. And if you sort of dig into the data, these are often rural communities where when we look at overdose deaths and rates of substance use, they're especially high. And when you think about accessibility to treatment and harm reduction services, they are lacking. So it's really a profound map, I think, to think about that this could happen again and is happening elsewhere. So then what do we know about drug use for people with HIV and AIDS? So the survey that I talked about, the National Survey on Drug Use and Health, it doesn't sort of break down the data by HIV in every iteration, but a set of authors did an analysis looking at the data from 2005 to 2014, and identified out of all the participants, about 0.19% of the respondents to the survey over that time frame were HIV infected. So what do we know? Well, what we know is that substance use is greater among HIV infected participants as compared to HIV uninfected participants. And that was true for lifetime, past year use, and past month use. So this table is looking at lifetime use, but shows that for all substances, the rates of use was higher among HIV infected individuals and statistically significant in almost all cases. And then when you break it down into past year use, similarly, we see that 46% of HIV infected individuals reported any illegal drug use as compared to 15% for unaffected people. And then how do the two conditions interact? Well, surely a substance use can be a risk factor for HIV transmission. So injection drug use is often thought of as a big one, syringe and all the other equipment. But we know too that sexual risk behaviors can increase associated with substance use. So people can use substances specifically for the purpose of facilitating sexual encounters. And that can come with a disinhibition and effects on decision making, which may make for more high-risk situations. Studies have shown more condomless sex and higher numbers of partners when substance use is happening along with sexual encounters. Chemsex is sort of the concept of using using substances to facilitate sex. And then some people engage in the exchange of sex for drugs or money to support themselves. We know that if a woman is pregnant and she has untreated HIV, that's an increased risk for transmission to the fetus. And so sometimes substance use in pregnancy can result in people not being as engaged in care. That's not universally true in any way, but if that's the case, it's an increased risk to the fetus. Diagnosis may be delayed if somebody's not engaged in care. And then there's been evidence to show that HIV can progress more quickly in the setting of substance use. Some studies have shown some effects on immune modulation with higher viral loads, increase in HIV mortality, and then HIV can have neurocognitive effects or effects on the brain, as does substance use. And so both put together make it harder to tease out and know what we're treating exactly, and can interfere significantly with a person's day-to-day functioning if they have significant neurocognitive problems. And then treatment might be affected. We'll get at it, I think, in a future slide, but for some people, they have more difficulty adhering to antiretroviral therapy. So there are actually recommendations from the panel on antiretroviral guidelines for adults and adolescents about, for people with HIV, what do we do about substance use? So the recommendations include that everyone should be screened for a substance use disorder and, if applicable, referred to treatment. Similarly, we should screen for mental health disorders. And substance use and mental health or psychiatric conditions are so intertwined that you can't really treat one without treating the other. It's really important to provide non-judgmental care, as I started with, and then to offer evidence-based treatment, both behavioral treatments and pharmacotherapy. And a big part of part talk 2 is going to be on that. And then people who use drugs, and I think I need to say, because I just think that this is a misconception among many people, but people who use drugs care about their health. Some people falsely assume that people who use drugs, like that if you use drugs, you just don't care about your health because drugs are bad for you. So how could you care about your health? Well, we probably all do things that, we all do things that are bad for our health, and yet we care about our health. And so it is false to think that people who use drugs don't care about their health. People who use drugs may have compelling reasons to use drugs. They may not be able to stop because of issues of dependence, and they need treatment to help stop. But people who use drugs should be started on antiretroviral treatment, and they can maintain viral suppression. It may mean that they need more structure, more support, more adherence support, more support from a pharmacy, case management, but they can do really, really well. When choosing a regimen, if you're in the position where you're the one choosing a regimen, it's preferred to use once daily single tablet regimens, to choose a regimen that has a high barrier to resistance so that if there are missed doses, they're less likely to develop resistance. Low hepatotoxicity, or like low risk for liver damage, especially if someone is using alcohol, which is toxic to the liver, and then lower potential for drug interactions. So sometimes the elephant in the room is like, oh gosh, how do I even start this conversation? How do I get at it? It just feels so overwhelming. And it can feel overwhelming. And so I'm going to talk a little bit about screening tools. I tend to think in general in life, what is most successful is what is easiest. That's not always true. But I spent most of my career in primary care, and there are too many things to think about on any given day. Too many diseases to screen for, too many boxes to check and forms to fill out. So the easier you can make it, the better. So thankfully, there are some screening tools that are called single question screening tools. And they are just that, it's a single question. And that's, they've been shown to be really effective in many settings, including primary care. And if you want to implement one thing, it can be a really good starting point to, find a way to ask about substance use in your practice or with your clients or wherever it is you work. So for tobacco, what that would mean is, in the past year, have you used any nicotine or tobacco products? And if yes, offer a brief intervention, which I'll talk about, with cessation recommendations or treatments. For alcohol, do you sometimes drink beer, wine, or other alcohol-containing drinks? It's always a good reminder to frame things in an open-ended, sort of positive way, not to say you don't drink. I'm always kind of feel like I want to say and I hold back, but I'll go to my own doctor's appointment and they'll say, you don't do, when I was pregnant, you don't smoke, do you? And I thought, wow, I just would not feel comfortable saying yes if I were. And so I can only imagine how that is received when questions are framed like that. And then for substances, how many times in the past year have you used an illegal drug or a prescription medication for non-medical reasons? And any answer other than never is a positive that you should then follow up and ask more about. And the reality too is that sometimes these can be longer, more in-depth conversations. And I like to think of sort of care as the long game. It's hard to sort of dig into all of this and understand why and how and when somebody uses substances and what experience maybe with treatment they've had and what their readiness for change is. And so you don't have to sort of ask the question and feel compelled to have everything together in one setting to wrap it up with a bow. And check it off and say I've done that. But starting to open the conversation and let the patient know that like you're a person who is receptive to hearing about it and working with them for change is important. So like I said earlier, we normalize alcohol in our country, and so people don't even understand what one drink means. But one standard drink is a 12-ounce can of beer, 12 ounces of beer in any can or bottle, 8 to 9 ounces of malt liquor, 5 ounces of wine, and 1.5 ounces of a distilled spirit. So vodka, whiskey, all those distilled spirits. And then the National Institute on Alcohol Abuse and Alcoholism defined at-risk drinking. And again, like there's so many definitions for low risk, unhealthy risk, at risk. But they set out these guidelines stating that for men, they should have no more than 14 drinks in a week and 4 in a day. For women and people ages 65 and older, no more than 7 in a week and 3 in a day. And I just saw and didn't dig into it, but that Canada came out with some far more conservative recommendations this recently, really recognizing that there aren't a lot of positive health effects from alcohol and far more negative effects. And I'm not endorsing those guidelines, but you may have seen that in the press recently. So I use the term behavioral and brief intervention, but it's kind of part of a bigger intervention called screening, brief intervention, and referral to treatment, which is a comprehensive integrated public health approach to the delivery of early intervention and treatment services. So, you screen, and then what the heck do you do? How can you do anything effective? Well, SBIRT is meant to sort of package this up into a digestible, feasible response to talking to and helping someone who uses substances in an unhealthy way. And there's evidence to support that brief interventions for unhealthy alcohol use can cause positive behavior changes for people. And a brief intervention is 5 to 15 minutes with a healthcare professional. It doesn't necessarily have to be a physician, or it could be a nurse, it could be a social worker, to help assess the person's understanding of their use, the health consequences, their motivations for change, and goal setting. So this is a flow chart to sort of capture the idea of SBIRT. Really important is that we believe in universal screening. So don't assume based on what somebody looks like, where they come from, what's going on in their life, that they do or don't use substances or have a problem with substances. Ask everybody. If they have no use or low risk use that doesn't have consequences, give them some really positive reinforcement. Reflect back to them why they're doing, whether using in a healthy way or not using, and why that's important. As a healthcare professional, what we say to patients holds a lot of weight. And so reinforcing positive behaviors is important, just as important as helping to modify less positive behaviors. If they use moderate or high risk amounts, offer a brief intervention. So again, talking to them to understand what's their motivations for change and doing some concrete goal setting. And then as you're able to provide treatment if that's in your skill set, or refer to treatment. The last parenthetical part of this box is a big ask, but as much as is possible, if you have assistants in your setting, to follow through to make sure they made it to treatment can go really a far way. I've had many conversations, and I work in the hospital where I see people who are hospitalized, and I don't have the ability to follow up after their discharge to know, did they make it to the place I talk to them about going to? Did they make it to that follow-up appointment? And when I get some sort of communication from that person on the outpatient world that they made it, it really, it warms my heart, but it also makes me feel more confident for the person's, that they're going to achieve whatever goals they set out. So I recognize, again, so there's always too much to do. So following up on treatment referrals is a big ask, but can go really far. There is a virtual training opportunity through the Wisconsin DHS if you're interested in some formalized training on SBIRT to develop that skill for yourself. And then just really a few quick words about alcohol screening tools. So the single screening question, maybe if that's where you start, that's great. But there are a few other. There's something called the AUDIT, the MAST, and the CAGE. These are questionnaires that some of them can be self-administered, some can be administered through an interview form. And you can find more information on the SAMHSA website. The AUDIT is what I see used most commonly. It's a 10 question tool. though there's a shortened Audit C version, which is only 3 questions. So shorter is, again, easier and good, and also has been shown to be a valid tool to identify people with use, problematic use. The score can go up to 40, sort of a esoteric detail you don't need to know, but as someone has more harmful use, the intervention is more intensive. So at low risk use, we again encourage reinforcing positive behaviors and educating. When they have sort of a lower 8 to 15 score, advising them about the risks for negative consequences. When there is harmful use happening, and making more of a purposeful advice to change, and then having purposeful follow-up to monitor. And then if they're dependent or have a higher score, it's recommended that either you or someone else do a full diagnostic assessment and refer for treatment. And then for other substances, there are similar tools, the NIDA Modified Assist, DAST, KJ, TAPS, and the opioid risk tool. I often sort of, so many talks in and of itself about, prescription opioid use and the development of addiction to prescription opioids. This opioid risk tool is one way in which people try to gauge risk associated with prescription opioids, but there hasn't been a screening test validated to actually screen for prescription drug misuse in primary care settings. As I said, I'm going to talk more in a couple weeks, September 28th, same time, same virtual place, and I'll be addressing treatment, sort of more specifics about what that means, both behavioral and pharmacotherapy, and then issues around treatment access, especially thinking about geographic and rural issues, and then talking about harm reduction and how you can be knowledgeable and incorporate that into your care, and then providing additional resources. So I've not been following the chat, but I guess I'll pull it up now, and I welcome questions.
Hi, thank you so much, Dr. Eden. We do have we have a couple comments, and I will read them. Love the language matters slide and would love to share it with colleagues. Thanks so much for this, Dr. Eden.
Yeah, thank you. I think on that slide, there might be a citation. There's a good article that outlines in more detail even. It might be called My Language Matters. I suspect you could Google it, or I could try to find it. And I don't know if you reach out to the coordinator of this session, I'd be happy to try to find it for you. But it really, I think, is so important. It's like working with respect and compassion with people is probably the foundation on which you can provide best care.
Yeah. Okay, so we do have another question. And it is there a reason why slide 24 did not specify the high percent of STEM-UD or combo use?
Is slide 24.
And I believe the comment is supporting his question. I have a slide that I use that actually shows the rise and fall of white BIPOC comparison, even though demographic use dropped 78 to 69%, while Black and Hispanic rose 8 to 12%, respectively.
Oh, there's my slide. Yeah, so the stimulant use, I think it just wasn't broken down in the data that I was looking at when I put it together, but the stimulant use, the high percentage of stimulant use disorder is very notable and important to recognize in our country. But I'd love to see that slide if you're willing to share. It'd be really interesting, I think, to see and incorporate for myself that kind of data in the future.
I can get that from the person who put that in there and make sure that you get it.
Thanks. Thank you, Ashley.
Mm-hmm. All right, next question. Can you discuss more on negative drug-to-drug interactions between antiviral treatments and some common substances that are used by folks who have substance use disorders?
So, I don't think of the substances themselves as having sort of drug-drug interactions in the way that we think of medications when we check drug-drug interactions. Probably one of the big exceptions would be alcohol and the liver toxicity that comes with alcohol use. There can be similar side effects. I mean, there can be side effects that may sort of be more or less pronounced with certain antiretroviral regimens. I mean, increasingly, I think a lot of our meds for HIV are very well tolerated, but there, some substances can be more likely to sort of cause psychiatric or like insomnia and drive things like that. But in general, I don't really worry a ton about the drug, like the illicit drug itself interacting with the antiretroviral.
Thank you. And I believe that was our last question, unless, oh, there we go. Are there specific populations where testing rates are lower?
So I don't know. I don't have a solid answer for that, but it's I suspect there are. So, I mentioned that HIV testing rates are lower among people who inject drugs, or maybe not lower, because 50% of the population being tested in a given year is still higher than the general population's testing rates, but lower than would be the goal, given the risk associated with injection. I think there's realities related to uninsured populations, or people with limited access to healthcare, be that geographic. I think I also just encounter in my own practice that a lot of medical providers aren't well versed in the national recommendations. So risks aside, the United States Preventative Service Task Force and the CDC recommend that every adult have at least one HIV test in their life, and then more frequently if they have risk factors. And I often find that, like, I'll be seeing patients and they've never had an HIV test, period, and they may or may not have risk factors, but I think people are less aware that every adult should have at least one HIV and hepatitis C test, and then more frequently has risk factors. So, but I can't speak to sort of, racial differences or geographic distance differences. I just am not familiar with the exact data on that. That's a good question, and I'm sure there are.
We had a comment that said, yes, they are lower testing rates in rural communities due to location, stigma, and several other factors.
Yeah, there just has to be.
Yeah.
I think, like, there's also small communities come with the fear of, like, I was taking care of somebody today who shared with me he has HIV, but he shared he really wanted a relationship, and he was really scared to talk. He didn't know how he would, since being diagnosed 5 years ago, had never had a romantic relationship and didn't even know where he would start to talk to potential partners about his HIV status. And he said, I live in such a small community, like there's like so few, like he's gay, and he's like, there's so few people in general, and then like everybody knows each other and they all talk, but the minute I tell one person, everybody's gonna know. And there are, realities with small populations and stigma that people fear that they don't want to ask for an HIV test because of the assumptions that might be made for why one would want that.
All right, I think, are there any more questions? All right, well, Dr. Egan, we'd like to thank you very much for your presentation today. And there are a lot of comments in the chat. They're looking forward to part 2. If you could take a look at the chat and please utilize the SurveyMonkey link to complete the evaluation for today's session in order to receive CME CNE, or social work continuing education, we would ask that you complete the evaluation within 2 weeks of today's presentation by utilizing that link. We will also follow up with all registrants with the link as well, in case you don't get it today, but we prefer that you do it today. Also, there are some resources in here for other presentations coming up. The part 2 link is in the chat. We will also follow that up with an email as well. And there is another presentation coming up with NAHU today, or this week, this coming Friday. And this registration link is the last one that was dropped in the chat, I believe. Nope, that was a session. I'm sorry, my chat is not up to date. But if you would like to attend NAHU's final session of the series, it is called the National ATC Resources for Clinicians Providing Care to People with Substance Use Disorder, and that is this coming Friday at 12 p.m. Eastern Time. Please utilize that link to register. If there are no other questions, this is Dr. Egan's contact information, and we will also provide a PDF of these slides on NAHU's resource page.
Thanks, everybody. Thank you.
Thank you, and enjoy the rest of your day.
Bye.
Thanks, Ashley, Liz, and especially thanks, Dr. Egan.